I think you never stop learning. So, introduction for those that are seeing my face for the first time, I'm Dr. Queen Ramarasi, and today we have a former classmate of mine. This feels more like a chill session than a formal session for me, but today we have Dr. Jason Harry. Dr. Jason Harry is a qualified anatomical pathologist, guys. And I think when you talk about pathology, all of us see the medical detective shows on TV. We're not really sure what pathologists do. I mean, you do get some teaching in there, but how do you even become one? That's the biggest question, I think. So, Jason, I'm just going to let you introduce yourself to the rest of the audience so everyone can get to know you a little bit better.
Good evening once again, everyone. Thank you to Queen, my former classmate, and Ben for extending me the invite to address you on this platform. It's a very gratifying experience, and I really hope to share more with you about the wonderful world of anatomical pathology and what it entails. So, like I said, my name is Jason. I'm an anatomical pathologist. I did my undergraduate training at the University of Cape Town, after which I did internship in RK Khan Hospital in KZN. For my community service year, I was fortunate enough to be awarded an NHLS post at Nelson Mandela Academic Laboratory in Mthatha. And over there, I chose to do anatomical pathology for the year. Following this, I completed my postgraduate training in anatomical pathology at Inkosi Albert Luthuli Central Hospital and the University of KwaZulu-Natal. I finished that in 2024. And last year, I started working at Lancet Laboratories Durban, which is a private laboratory. Yeah.
Very, very exciting stuff. RK Khan, internship. I mean, we've heard horror stories about RK Khan. We're not trying to say anything, but how was the experience there and your transition from there into straight anatomical pathology in your community service?
So initially, when I was placed in RK Khan, I also had that reaction. I was petrified. But at the end of the day, I'm so grateful I did my internship there because I entered RK Khan as a timid, um, very unsure of myself, fresh out of medical school. But there's such a strong sense of team, community, and togetherness there, and putting the patient first and getting the work done. And the nurses took care of me. We formed a tight unit as our intern body. And at the end of those 2 years, I felt confident and competent to tackle anything. And I think that's what I took from my internship. It doesn't matter where you are, it's who you are with and what you take from that experience that ultimately shapes whatever path you take in the future. And as difficult as it was, I wouldn't trade it for anything because I learned so much and I really grew in confidence and competence, like I said.
Yeah, no, that's actually great. And I like what you said that you know how you stress about those five choices in internship. You're like, can I just go to the Western Cape or can I just go there? But I think internship is just tough wherever. It doesn't matter where you are in the country, internship is just tough. And I think how you enter it, anxiety, anxious, unsure of yourself, but when you come out of it, there's always like utility in terms of the experience that you had, then of course you make
Yes.
it what you want it to be, depending on the teamwork, of course, or the team that you're actually working with. That's actually very interesting. And then for now, the jump actually from clinical medicine in internship into anatomical pathology in community service. How was that? Like, how did you even find anatomical pathology? What sparked your love for anatomical pathology? Before you actually tell us what is anatomical pathology for those that don't know what is anatomical pathology.
Okay. So in the second year of our curriculum at UCT, we start all of the pathology disciplines, and anatomical pathology forms the bulk of everything in that pathology year. Apart from, we do chemical pathology, medical microbiology, virology, immunology, but ANATPath forms a significant component of that because it really links everything. It involves chempath, it involves micro, and so on. So we started anatomical pathology in second year, and one of our courses was the special studies module, during which you undertook a research elective for 4 weeks at in any discipline of your choice. Now, I had always enjoyed pathology from our first few lectures. I remember our first lecture was on acute inflammation, and I thought it was very interesting because you study medicine because you want to learn about diseases and how to treat them and better the lives of your patient. And in first year, we're just learning normal structure and function of the human body. And when we started learning about diseases for the first time, I was completely fascinated because I felt like, oh, okay, I'm learning what could go wrong in my future patient. And, this is where the real medicine is starting. So I did my special study module in pediatric pathology at Red Cross Children's Hospital under the supervision of Professor Kamla Pillay, who's now the HOD of pathology at UCT. And I basically looked at an audit of the intraoperative frozen section service at the Children's Hospital, whether or not it was meeting its targets, what range of diagnoses were being made intraoperatively, and so on. So since then, I had caught the bug for a NatPath, so to speak. I really grew more fascinated with the lectures. Even in fifth year gynecology, my consultant knew I liked the NatPath. She let me leave theater to go and take the sample and go do the frozen section with the NatPath people. During my internship year, my consultant in internal medicine, he would quiz me on the histology of a renal biopsy. So I had always maintained that love of histology and pathology, and I took these in whatever clinical discipline I went to. The other clinical disciplines I enjoyed were internal medicine, which, like anatomical pathology, involves all areas of the human body. So I like something that, covers the entire spectrum. But I think at this point, I should just explain what anatomical pathology actually is. So, anatomical pathology is the branch of medicine that deals with the diagnosis of disease at the tissue and cellular level. Compared to chemical pathology, they deal with the diagnosis of disease in all bodily fluids. So this can be urine, CSF, pleural fluid, blood, protein, plasma, and so on. Hematology looks at disorders affecting the blood and the three components of the blood, lymphocytes, platelets, and so on. So your blood, red blood cells, white blood cells, platelets. And then medical microbiology and virology look at the infective causes of disease. Now, all of us fall under the discipline of pathology. In the College of Medicine, we have a College of Pathology, under which we have a NatPath, ChemPath, MedMicro, Viro. Forensic pathology, which I'll touch on later, um, is a separate college on its own, but there is a lot of overlap. So the transition came in internship. I had to apply for a community service post. And quite recently, this was in 2020, they had introduced NHLS posts to be part of the list of options available to complete your community service. So I applied for the one at Nelson Mandela Academic Laboratory and Walter Sisulu University. I got it, and I started there in 2020. This was prior to the worsening of the COVID-19 situation. And I was very fortunate, and everything at this point really worked out. And I started that year in a NatPath, and I learned how to cut specimens, how to process them, how to look at them under the microscope, how to report them, and how to, translate what I was seeing at the microscope into clinically relevant findings for the clinicians that we reported for. So it was a
That's
huge
actually very
jump. It was a
interesting.
huge jump, but yeah.
That's something that's actually very interesting. I think it's like a light bulb moment for me because when it comes to lab medicine, you do interact with pathologists in your first year, second year as lecturers. But
Mhm.
in terms of the work that actually they do, I think you broke pathology nicely for us to understand.
Mhm.
And I think I have a lot of questions with regard to anatomical pathology. But the question that I have to ask is, anatomical pathology itself. In the beginning, you were like internal medicine, and then you decided on anatomical pathology. How is the training or entry into specialization like? What are the requirements, and how
Okay.
was that journey for you?
So the pathway to become an anatomical pathologist generally has very few requirements. So you need to have completed your MBCHB, you need to have done your internship and your community service, and you need to be registered as an independent medical practitioner. So at this point, certain disciplines require you to have, like say, for example, emergency medicine, you need to have your ATLS and, certain surgical courses done. Anesthetics requires you to have a diploma sometimes that stands you in good stead. But with anatomical pathology, there aren't really any prerequisite requirements. All you need to have at that point is an interest in the discipline, an understanding of what it entails, and you just need to be registered as an independent medical practitioner. So very few requirements. So when you apply for a reg post, the posts are funded by the National Health Laboratory Service, or the NHLS. Now, the NHLS funds these posts in conjunction with the associated teaching university. So, for example, I was appointed at Nkosi Albert Lutuli Central Hospital, which is the Durban Quaternary Teaching Center, and the affiliated university is the University of KwaZulu-Natal. My post was funded by the NHLS, and my contract was for a duration of a minimum of 4 years. Now, for like most specialties, there's a part one and a part two exam, which is administered by the Colleges of Medicine South Africa, the CMSA. Unlike the surgical disciplines, which can be a little bit longer than 4 years of postgraduate training, and you require intermediate exams and so on, and NatPath only has a part one exam and a part two exam. The other requirement is that in your 4 years, you also undertake a research project as part of your Master of Medicine dissertation, and you submit that thesis upon completion, and you have to have that and your two exams in order to be able to qualify as an anatomical pathologist. If you have one or the other, you cannot register with the HPCSA as a specialist in anatomical pathology. Now, your part one exam, you write at 18 months, 1.5 years into the program. That is the benchmark that you aim for, and it covers essentially Robbins pathology, which is the textbook we use at medical school. And it just looks at general and systemic pathology from a purely theoretical level. And the 30 slides that you do in your prac exam cover fairly simple, straightforward diagnoses. Your part two exam is multifaceted. You write two theoretical papers covering all aspects of anatomical pathology in great detail. You also write on cytopathology. You do an autopsy exam and OSPEs, looking at various practical components. So I should tell you at this point that the scope of learning in anatomical pathology generally, we split it into about 70% is histopathology or surgical pathology, where we look at biopsies, resection specimens, and so on under the microscope. The next 10 to 15% is cytopathology that looks at either gynecological specimens like your pap smears and your non-gynae specimens like your fine needle aspirations, either from the thyroid, bodily fluids, and so on. And the remaining percentage, it's for autopsies. Now, to write your exams, you need to have done a minimum of 50 autopsies in your 4 years. But the rate of autopsy requests is generally declining. And that's why autopsies don't really play such a big role for us in a NatPath. But for forensic pathologists, they are their bread and butter. And I'll explain more when we go into the different aspects of what our day entails. But I think that just
Mm.
covers the general idea of what the road takes there. Yeah.
Yeah, no, Jason, that sounds very intense. I remember, the pathology textbook is like this size.
Yes.
literally, and it's like fine print with lots and lots of pictures. Can
Yes.
be quite overwhelming. Like,
Yes.
it feels like a lot. So the training program itself, with in terms of the learning, also trying to do this MAD that needs to be completed in 4 years' time, but also preparing yourself for the exam, but also doing the work itself in the lab, learning the different techniques and pushing, the service done by the NHLS. How did
Yes.
you actually do it? What kind of tips and tricks can you give people? Because I think no reg time is like a walk in the park, but given the
Yes.
voluminous work that you guys need to do from head to toe skin, I'm sure you get like samples from every part of the body, and you need to have like understanding of every single tissue when it's normal versus when it's not normal. How did you actually like navigate that,
So I think
managing all of that?
I think it's an ongoing learning process, and the important thing is to be kind to yourself and realize everyone is learning every day. For me, especially as I got to the senior part of my reg time, I always kept in mind the end goal. And what I did was above my desk, I listed my goals and what I wanted to achieve by a certain time. So I would say, for example, okay, 2022, part one needs to be done. 2023, MED registration needs to be done. 2024, register for part two, complete part two, etc. So it's important to keep your goals in mind. And when you have them able, like in front of you and able to visualize, then that's great because it keeps you motivated. Also, the volume of work in a nat path is significant. And apart from learning the whole body, each body system has its own specialized textbook. Like there'll be a textbook on placenta, a textbook on liver pathology, dermatopathology. And this reflects the vast accumulating knowledge of diseases that we are gaining now, even as we enter the molecular age, where we have advanced molecular techniques to pick up genetic mutations in certain tumors. But in more developed countries, you can subspecialize and do purely dermatopathology if you like skin, or purely hepatobiliary pathology if you like liver and pancreas and so on. At present, it's not possible in South Africa because we have such a dire shortage of anatomical pathologists. So you have to function as a generalist. So that's why the training program in South Africa is not aiming to make you a master of all the different pathology disciplines. You just need to be able to practice as a safe, competent pathologist, be able to identify what is normal, what is abnormal, and when to ask for help and refer. A safe pathologist doesn't practice with an arrogant mindset and diagnoses everything. He looks at a slide, he acknowledges his limitations, and if it's beyond his scope, he requests assistance, a second opinion, second appraisal from a senior colleague, or even internal and external consultation as appropriate. Many cases for us in Lancet, for example, if it's soft tissue, we'll send it to one of the soft tissue experts in the country. Or if it's something pediatric pathology, we send it to UCT because they look at a lot of peds cases as well. Even some of our nervous system tumors, we send it to Stellenbosch because they have, the expertise to, because they see such a high volume of these cases. So the workload is considerable in what you have to be able to be conversant and fluent in by the end of your 4 years. But we are told from the outset, like everything in medicine, it's constantly adapting, constantly learning. It is impossible to know everything, but you should just be able to function as a safe pathologist, know your limitations, but also be equipped enough to know how to address those limitations. If, for example, you get a skin biopsy and they are querying a melanoma, you need to be able to see, okay, this is a melanotic skin lesion. Is it benign? Is it malignant? What stains do I need to order? What does it mean for the patient? Am I reporting it correctly in terms of, is it excised? All the margins are clear, etc., etc. So it's important to, not be overconfident, but know how to address knowledge, gaps in your knowledge. And I think that's what makes an AdPather so nice because the road to learning never ends. like everything in medicine, and this is especially true in an path.
I think you're building confidence in us to actually, give pathology a chance, give
Yeah,
anapath a chance, because as
ex-
much as the work is a lot, it sounds
yeah,
like it's reasonable. When I say reasonable, I mean the expectation is reasonable. So
yeah.
how do we actually get in? What are some of the things that people can actually do to set themselves on a path to anatomical pathology? I mean, people are going to listen to your videos, they're going to be like, I think I like that at different
That's
stages,
it.
maybe from students to MOs to be like, you know what, I think next time NHLS put those posts, I just need to put my name in there. How do we actually get in? What are some of the things that they're actually looking for? Like on your CV, how do you actually prepare yourself so that you become a successful candidate? Should
So
they post be open?
So, firstly, just keep an eye out on the NHLS website. They have a page where they talk about job opportunities and applications, either for internal or external applicants. So, just keep an eye on that because they update those regularly for registrars. There's usually an intake around, well, the posts I know get advertised around July and then again around October or so. These are subject to change, but they usually advertise for registrar posts twice a year. And just keep an eye out in the middle and the end of the year. Secondly, what's really important, and this, and I've sat in on interviews, this really stands a candidate in good stead, is if you visit the laboratory. It doesn't have to be the one you want. Say, for example, you're in your community service year and you are in, for example, somewhere in Johannesburg. Go to Wits, asked to visit the laboratory, people will be more than happy to take you in. It doesn't have to be, and even they say this on the application form, it's recommended that you visit one of the laboratories. Like I said, it doesn't have to be the one you are applying to, your first choice, but just so that you know what the workflow for anatomical pathology entails. So visit a laboratory. They will make you shadow a registrar. You will engage with the consultants. You will engage with all levels of laboratory staff and see what they do on a daily basis. Because unless you make time in your years as an undergraduate student, you will never be fully exposed to what laboratory medicine entails and what happens from reception, where a specimen enters the laboratory, to report and diagnosis, where the output is generated for the referring clinician. So you just have to email the secretary, the academic secretary of the respective department, and express your interest to apply for a reg post and ask to spend a few days. It can be two days to a week. It doesn't really matter, but as long as you show some initiative that you are willing to see what lies ahead for you, should you be truly interested in this career path. Another important thing that this visit shows you, um, and it applies to all pathology disciplines. Like if you want to apply for micro, do the same. You need to be able to see what is expected of you before you actually apply, so that if there are any lingering doubts or questions in your mind, you can clarify these before you actually submit your application. And the thing is, all pathology disciplines, we are incredibly happy to take potential new recruits through the laboratory and just show them and engage with them what we do on a daily basis. Like they refer to anatomical pathologists as the doctor's doctor because clinicians depend on our results to guide their management. And we really are a small fraternity and we are always willing to show anyone who expresses any level of interest what we do so as to give them some form of encouragement and inspiration to join us. So yes, just make an attempt to visit the department you want to apply in, and yeah, that will stand you in a very good stead.
Yeah. And then, of course, so basically, you do medical school for like a roadmap, medical school, internship, ComServe, and then from ComServe, you can just apply for
Yes.
the following year. Like the ComServes this year can actually apply now in July for the
Yes.
intake of July or in October.
But,
That
because they would need to complete their ComServe year and get their completion of ComServe certificate for the registration as an independent medical practitioner. But the
okay.
intake for January that's advertised at the end of this year, I would recommend they apply. And
Okay.
I know ComServe facilities are different. Sometimes it's difficult to take leave. But the thing is, the lab will always accommodate you, and because essentially you're just going to shadow, and the requirements for your visit aren't that strenuous, and they will be able to work around you in terms of your leave and whatnot. The other thing I would recommend is, if you truly are interested in an ad path and all it ticks all of your boxes, start going through things early, because your first year you are learning the language of pathology, what you do in the cut-up room, how to look at slides, how to do autopsies, how to cut specimens. It's a lot to take in, but you can make your life a lot easier if you get a head start on your theoretical component. And everyone will have a copy of Robbins or some similar basic pathology textbook from med school. Just go through your pathology notes again and have an understanding of the different concepts. So in general pathology, know what inflammation is, be it acute or chronic, know what neoplasia is, what autoimmune diseases are, and so on. Just start engaging in that again and as a refresher. For example, if you are about to, write your diploma in anesthesia, you start revising physiology, things like that. And even internal medicine, you're learning through like your cardiology rotation. You'll go through the ECG again and physiology of the heart. The same applies to a nat path. You are interested in it, just go through at your leisure your basic and systematic pathology before you get to the program, because it helps you. Whatever you can do now to make your life easier later, it helps you in the long run.
Hmm. Okay, so I like the fact, the only thing that I like is the fact that they don't need experience. You guys are willing to groom us from from scratch. But of course, most of us, we do have some basic understanding of anatomical pathology. So you talked about your work being cytology, and then you also do like frozen sections and like anatomical diagnosis of the samples that we send to you, like the surgeons or the biopsies that we send to you, but also an element of autopsies. So my question is, what is the difference actually between anatomical pathology and forensic pathology? Because I think they're very close, but you guys do different things, or am I
Yeah.
wrong?
No, no, 100%. So, although both fields involve pathology, their objectives are fundamentally different. So, anatomical pathology focuses on diagnosing diseases in living patients most of the time. So, we examine biopsies, surgical specimens, and cytology samples. So, in terms of the samples we receive, they can be small core biopsies, endoscopic biopsies from anywhere in the GIT, complete excision biopsies where we take a complete lesion out, like removing a skin cancer, or complete resection specimens, like removing an entire segment of colon. The cytology specimens we receive, they can range from the pap smears, like I mentioned earlier, or to exfoliative or non-exfoliative cytology. So taking an aspirate from a thyroid, from a breast, and so on. Now, where there's overlap is the area of autopsies. Now, we do autopsies for natural deaths. So, say, for example, we have a patient who is sick in hospital, there's no suspicious circumstance, we will do the autopsy. But because medicine has advanced and it's continuing to advance, the diagnosis or cause of death can be made a lot of the time without an autopsy. It's usually an academic exercise now, which has become quite sad because we learn so much from autopsies. Now, I want to contrast this with forensic pathology. Forensic pathology focuses on investigating deaths, particularly those that are sudden, unnatural, suspicious, or legally relevant. So there's a huge medical legal implication or involvement with forensics, and they are frequently called to testify in court to report on their findings at autopsy. So a forensic pathologist wants to know who died, how did they die, what was the cause of death, what was the manner of death. And just to use this as an example, in anatomical pathology, we may diagnose a lung cancer from a biopsy, while a forensic pathologist may determine whether a death resulted from natural disease, homicide, accident, or suicide. So the overlap is in pathology, but the purpose and the practice environments are quite different. Also important, forensic pathology follows a similar training path where they have a part one exam, a part two exam, and an M.Med dissertation. However, in forensic pathology, they spend a year in a NAT path. So it's usually in their first or second year of reg time, they will spend that whole year with us in a NAT path. So when I was in first year, we had our four new registrars in anatomical pathology, but we also had two registrars from forensics. And now these registrars in forensics, they spend the whole year doing everything an NatPath registrar does. So they will learn how to cut a specimen, how to look at it under the microscope, and so on. Because by and large, a lot of the work they do in forensics can be diagnosed macroscopically at autopsy. But in certain cases, say for example, there's an infarct in the heart, or there's some kind of infection in the brain where they're querying TB, they will look at slides under the microscope as well. So there's a certain level of microscopy that they need to master before they go and write the exam. So that's why forensic pathologists will learn general and systematic pathology with us for a year and then go back to forensics to learn the more complicated forensic maneuvers and skill set that they need. For example, how to determine if the cause of death was asphyxiation versus blunt force trauma. They need to know a little bit more on that end, but the basics they learn with us before going back to forensics. So essentially, 25% of your training as a forensic pathologist will be shared with a NatPath. And just to show you, our part one exam, the theory component is exclusively based on Robbins' pathology textbook. The same applies to forensics. Their part one exam is exclusively based on Robbins' textbook. So that's where we overlap. In terms of the pathology we learn, there's a lot of, central commonalities. It's just that the implications, our patients are living most of the time. We're making diagnoses in real time. And like we diagnose the cancer for the patient, and then say a patient dies of cancer and the suspicious circumstances, the forensic pathologist will be able to determine whether or not, for example, the surgery is what caused the death, or if it was actually natural and the patient died of the cancer. So it's the whole medical legal aspect that distinguishes forensic pathology from anatomical pathology.
Mm. That's actually very interesting. I didn't know that forensic pathologists also spend time in anatomical pathology, but it makes common sense that you need to understand sometimes the microscopic
Mm,
level because sometimes in an autopsy things are not that clear. Just
yes.
for educational purposes, for us as clinicians working in the hospital, for academic autopsies where it's a patient, a young patient, maybe they came with this, then you thought maybe you're treating them, they were getting better, and then they demise, then you want to, send the body for autopsy just to find out the cause of death. In most provinces, I've noticed that we don't have anatomical pathologists, and I think one interesting thing that you said was that anatomical pathologists actually it's almost like a dying specialty. I don't know if that's a thing. So honestly, the purpose of this is to encourage more and more people to actually go into anatomical pathology. But for
Yes.
us clinicians, who can we send for if you're in the bigger cities, Cape Town and Johannesburg, where you do have access to anatomical pathology more than the rural provinces, who qualifies actually for autopsy via the anatomical pathology route?
So anyone, and just to clarify, like when I was a registrar in Durban, so our academic training center is in Kosi Albert Lutuli Central Hospital, we would receive sometimes requests for autopsies from hospitals as far as Stanger, which is like a good, 45-hour drive to hour drive away on a good day. So if there's a compelling indication, even if you are in a peripheral hospital, you are more than welcome to contact us and liaise with the pathologist on call, and they will, accept the request if it meets the criteria. So when I say accept the request, like if it is truly does not tick any of the boxes for a forensic autopsy. If there is something about the death that is unnatural, say for example, the patient died um, on the table in theater within less than 24 hours. That goes in the territory of forensics because now the anesthetist is implicated, the surgeon is implicated, and if there's a physician man. So if that's why the anatomical pathologist who receives the request will look at those criteria. And if it's not for us, we will liaise with our colleagues in forensics and say, listen, here's an autopsy. It looks like it's, for you guys, but if there's anything you need help with, like if there's a tumor, then you're more than welcome to contact us. But like I said, you just need to know who your referring hospital is. And for example, in Cape Town, it's the NatPath at Stellenbosch UCT at it's Walter Sisulu / Nelson Mandela in Eastern Cape, and UKZN Albert Lutuli in Durban. So you just need to know your main training center. And funnily enough, like other pathology disciplines like micro, chempath, they can work at peripheral labs. And more often than not, we have a micro or a chempath at the smaller labs. However, a NatPath, because of the nature of our specialty, it's very difficult for us to split into smaller labs. That's why there's one main lab, and that's where you'll find all the NatPath. There was a very scary statistic which I was told by my HOD when I was a registrar. At the time of my training in 2021, when I started, there were five anatomical pathologists in the state sector in KZN, and they are servicing the needs of 80% of the province in terms of histopathology services, whereas the remaining 20% is seen by close to 20 histopaths in the private sector in KZN. So that is why I'm hoping this really inspires people to join the program, because we really do need anatomical pathologists, and it's a wonderful discipline. And we really like engaging with clinicians. So if you do put this request through for an autopsy, we love that engagement. We work from behind the scenes. And that's why, they always there's this perception that, pathologists are these aloof and unapproachable doctors, but we really are not. Like sometimes we receive a request for on a biopsy, and the form, it's not giving us the full picture, and nothing stops us from picking up the phone and calling the clinician and having a discussion about what, you know, ultimately it ensures that the report we give out is of quality, but also the correct diagnosis, and it's of, doing justice to the patient. So we are very approachable. So if you have a request for an autopsy in the state sector, like, just contact your referring hospital and they will make a plan if it meets the criteria for a natural death assessment done by an NatPath.
Mm. Right, guys, we need more anatomical pathologists. I hope this inspires someone who, because I don't think it's because people don't want to become anatomical pathologists. It's just that it's a discipline that's not well
Yeah.
represented and advocated for because there is room for it. If you have only five pathologists covering a province like KZN in the state sector where 80% of the population rely on that service, it's problematic because now you have all the surgical specialty, including medicine, sending samples. So it can get quite overwhelming for those five pathologists. So I don't know if the pull factor is money or what to private. I don't know. I'm just curious to know why people are not staying in the state sector.
It's multifactorial, and it's a lot of the time it's like, logistical issues that are well beyond our scope, and creation of posts. Like I left because there wasn't a post at the time. But a lot of the times I know, like, sometimes it's a financial reason to leave for private, like many other disciplines. So I think, it's short-sighted to put pathology in the, like, not really prioritize it, because like up to 70% of diagnoses in clinical medicine depend on your pathology results. And like you may see, even ChemPads, like we're a private laboratory, but we have at the moment two hematologists, and they are on call every alternate day. And that is incredibly stressful, time consuming. There's just a severe shortage of pathologists in general, but anatomical pathologists are really suffering. And I feel like it also boils down to the changing of the curriculum at the undergraduate level. Pathology is, it's often sidelined, and, people's early exposure to the discipline is not always that great. They have intimidating lecturers, or the work seems frustrating, and they don't, for example, people know more about what it takes to be a pediatrician because they spent a good full-time block in fourth year, but in fifth year, sixth year, they spend a good amount of time in that department. Whereas in that path, how are you going to truly understand the discipline if you don't, know what it entails? So I think, those are issues that are, really a problem. However, what gives me hope is that more and more as medicine evolves, people are realizing that, pathology is so important. Like these days, with breast cancer, the advances in identifying mutations in certain tumors, ongoing areas of research. It's so exciting from us as pathologists, but also it means so much more can be done for the patient. And this year, especially these past 2 years, like having finished and engaging more with oncologists, they request for so many specific genetic tests that can help improve management for a patient. For a patient with melanoma, they look at BRAF mutation testing, and this is not really, the realm of any other discipline, but like in pathology. So I think at some point or the other, people get exposed to pathology, even if they subsequently encounter it later in their lives and they see the value of it. And even if you don't enter pathology straight after community service, that's fine because whatever clinical exposure you have also stands you in good stead. So yeah, it's a multifactorial issue why we don't have, but then this is also the case worldwide.
Mm.
So we are a dying specialty, but we hopefully are attracting a lot more people. Because I know, for example, at the University of Cape Town now, I think they have a registrar body of close to 18 registrars, which is fantastic. And UKZN, my other alma mater, they took on an intake of, I think, at least 4 registrars last time I checked, and the department was stabilizing again. So there is a lot of hope, and people are passing the exams and they are qualifying. And, there was this time where, prior to COVID, where it looked very dire and scary because not many people were passing the exams. But then there was a change in how assessments were carried out across the board. And more knowledge is tested in a fairer way, if I could put it that way, and such that we are producing safe, competent pathologists without, without being bogged down by unnecessary forms of assessment. And this will continue to improve as the younger generation of histopaths, become more and more experienced with the CMSA and so on.
Mm. I honestly do appreciate conversations like this because I think this is quite an eye opener for us. Because remember, as clinicians or as surgeons, when you work in the hospital, I don't think we appreciate pathologists as much as we should. So, what does a day in your life look like?
Hmm. So, okay, so a typical day, I have a caseload of approximately 40 cases. And this can range between your small gastric biopsies, your mastectomy specimens, bone, renal biopsies, skin biopsies, and so on. These I report routinely, and I get the slides, look at the form, get the relevant clinical history, and you report it, you dictate it, and you sign it out. Some cases, like certain tumors, require certain stains for a diagnosis. For example, a breast cancer needs your estrogen, progesterone, and HER2 markers to show what type of tumor it is and dictate management. I will order those stains in the morning. I'll get them the next day and then report those. Another service we offer is cytology. So we look at pap smears and those other non-gynecological specimens I mentioned. A big part of our day also revolves around intraoperative frozen sections. Now, what a frozen section is, and I realize I didn't mention it earlier, basically, your normal routine biopsy, if we receive it today in formalin, it is processed overnight for reporting the next day. That's why our turnaround time for a biopsy is a minimum of 24 hours. An intraoperative frozen section is different because usually, like I said, if something is received in formalin, it is put in a a tissue processor where the tissue is dried in increasingly purer concentrations of alcohol overnight. The next morning, it is placed in paraffin wax, and then that makes a solid block that we cut sections that are very thin, placed on a slide, stained to look under the microscope. So that process takes a whole night. However, with the intraoperative frozen section, whatever tissue we're looking at, we report within 20 minutes. So what happens is the tissue is received fresh. In other words, it is not put in formalin. We are usually in theater with our technologist. We take the tissue, we freeze it rapidly with liquid nitrogen, and we cut and stain that tissue in the room next to the theater, and we give a diagnosis to the clinician within 20 to 30 minutes. It's usually less than that, though. For example, with a patient with a breast carcinoma, we look at the sentinel lymph node. Now, the sentinel lymph node is the node in the axilla of the breast where the tumor is. So say if you have a breast tumor in your right breast, the surgeon will use imaging to identify the first lymph node in the immediate proximity to the tumor. So the sentinel lymph node is the first node where the tumor could potentially spread to before going down the rest of the lymphatic chain and lymph nodes. So what we do is the surgeon cuts that lymph node out. We cut it and stain it, and we see if if there is tumor in the node or not. So say, for example, I get a lymph node and I'm not seeing tumor. I will report it to the surgeon as this is a reactive lymph node, negative for tumor. What that means is he proceeds as normal. He doesn't do any radical surgery. He can take out the tumor and just take out that lymph node. However, if that sentinel lymph node biopsy has tumor, then he has to do what is called an axillary lymph node dissection, because what it means now is that the tumor has already spread to the first lymph node. There is a high chance and propensity that the tumor is now spreading along the rest of the lymph node chain. So what he does is he takes out all of the affected lymph nodes in the axilla, and we look at that under the microscope the next day. So you can see the diagnosis we make at frozen determines the extent of surgery that the surgeon undertakes. And it's not just for things like breast carcinoma. For example, the other day, I had a patient for a frozen section that had a gastrointestinal stromal tumor in the stomach. But now he had a nodule in his lung, and the cardiothoracic surgeon was worried that it was a metastasis. If it was a metastasis from that tumor, he would have had to take out much more. So he took out the nodule, he gave it to me in theater, and immediately when he cut it, we saw this caseative type necrosis. Now, when we say caseative type necrosis, we immediately think of TB. So I took a section of that nodule, looked at it under the microscope, and I saw necrotizing granulomatous inflammation. So I told the surgeon, this is a necrotizing granuloma. The favorite diagnostic consideration is that of a tuberculous etiology. Now, I cannot call it TB for certain without doing my special stains. So that was enough. All he needed to know that it wasn't tumor, and we took out that nodule, and that was it. The next day, I did a Zeal-Nielsen stain, which is a histochemical stain that looks for acid-fast bacilli. There were acid-fast bacilli present in that specimen, We sent it for TB PCR, which was also positive. So this patient was commenced on TB treatment. So quite scary is that everyone thought it was a metastatic deposit from the tumor in his stomach. However, it was TB. So you can see how the decisions we make at Frozen can affect management. And sometimes it's not always easy to make a call. And me, especially really to be early in my time as a consultant now, you're always faced with diagnostic dilemmas. But like I said, you need to know your limitations, especially the limitations of Frozen, and sometimes you have to defer a diagnosis because, say, for example, the surgeon, and even in neurosurgery, Queen, like they give us a relatively small sample, and we are unable to say whether or not is tumor or like normal brain. So we say we are unable to make a diagnosis on this submitted tissue. Please could you send more? So then after the first frozen, they'll send another sample and we'll check until they have a diagnosis. Other indications for frozen, it'll be plastic surgery when they're removing, say, for example, squamous cell carcinoma in the cheek, for example. It's a very sensitive area for cosmetic purposes. They remove the tumor. We will look at all the excision margins to see whether or not there's tumor present at the excision margins. And if there is, for example, the surgeon will submit another margin and then ensure that there's no residual tumor left on the skin. So yeah, that's the frozen section service. I think that was an important thing we needed to cover as well.
Yeah, no shame. Yeah, like how for us, you send off your sample, and sometimes it can take up to 6 weeks for the results to come out. So I'm assuming that's most likely logistical slash work volume in the centers themselves. Because I hear you saying you're getting results quite relatively within the first week of actually getting the
Yeah.
tissues, whether frozen section
Yeah.
or resected
Yeah.
samples.
I should probably talk about turnaround time as well because turnaround time is huge. Like in private, your turnaround time, expected turnaround time is within 1 day. Even if it's a difficult case, you need to be able to at least give a provisional. So if you are seeing a weird tumor from the lung, you need to be able to sign it out as the features confirm a tumor. Further workup is being undertaken with an addendum to follow. Now, in teaching centers, the turnaround time is different because remember, you have registrars who are checking the cases in conjunction with their attached consultant. So for an urgent biopsy, the turnaround time is 24 hours. For a standard routine case that doesn't require workup, it's 3 days. For a case that requires stains like immunohistochemistry, it can be up to 2 weeks, depending on staff and whether or not they have the necessary stains. And then for cases that require molecular, like a soft tissue tumor that requires a specific molecular test, that can take 6 weeks. The other thing I should probably mention is that there are severe staff shortages, and that is why, your cases in a teaching center can take long. So the most important thing is then you pick up the phone and you call and you inquire about your result because, you know, um, the pathologist, the registrar are always happy to give you whatever feedback they can at that point telephonically, and all of that will be documented. So, yeah, and I know, like, there's this huge issue of this backlog of cases, but they are trying to offset that. There are attempts and measures being instituted to ensure that, result turnaround time is minimized for patients. And that's why some of the work is reported by us. So in my daily cut up of about 40 cases, about 15 to 20 are from state, and the other half will be from private. So we do look at a mixture of cases, which is really great. And yeah, that explains turnaround time. So I just wanted to point out that not everything is straightforward. For example, I can get a gastric biopsy, put it under the microscope, and call it mild chronic superficial gastritis. However, I can get another gastric biopsy where I'm seeing atypical cells that do not look like lymphocytes. An alarm bell goes off in my head. Okay, could this be a lymphoma? Then I need to do a panel of stains. Sometimes those stains come back, they're not helpful. You need to send it for consult. You need to, at the end of the day, the delay is in the sense that you need to get a correct diagnosis. And, we welcome anyone, any clinician who is sent in a biopsy to call us at any time. We handle a large part of our day is handling calls. It's clinicians wanting urgent results or they want to give additional information because a report didn't make sense. We have a lot of engagement with our clinicians and we don't practice in isolation. I'm sure the line you see on a report where we say clinical pathological correlation is recommended. I know clinicians hate that, but what I love about it is that it's not just passing the buck over to you, it's trying to initiate a conversation. So, like, if I get a liver biopsy and I'm seeing a hepatitis, I can only say what I am seeing under the slide. I'm seeing inflammation and I'm seeing all my negatives. There are no viral cytopathic changes, no granulomas, no features of steatosis. Now it is up to you as the clinician to tie the loose ends together because you have access to that patient's history. You have access to their serological results, their biochemistry. You can tie it together and make the ultimate comprehensive assessment. Having said that, we also, are the definitive endpoint for many diseases. And I think a huge chunk of our work lies in the diagnosis of cancer because the gold standard for cancer diagnosis is tissue confirmation and biopsy proven, results. So yeah.
That's actually such cool work that you guys actually do. That's so cool. But I think, you've said all the brilliant and amazing things that I think sort of sells anatomical pathology for us. But in terms of your training, what are some of the challenges that one would face, and then also work-life balance? Is there work-life balance there? What does your call look like so that people can actually gauge mentally for themselves if it's something that's doable?
So I think a few of the downsides of being a registrar in anatomical pathology really overlap with being a reg in any discipline. I think when you enter your reg time, the difficulty is balancing your commitments to your family, your partner, your home, with studying, your service work, and other commitments that are stipulated in your contract. Finding that balance can be tricky. But there are measures like, for example, at UKZN, they had active mentoring sessions for first year registrars to show you how to, navigate that sense. You have access to student support all the time. The workload in ANATPATH is intense. Like now in private, we see around 40 cases a day. But as a reg, remember, this is a completely new language for you. You looking at a biopsy for the first time can take you like a good half hour. What can be second nature for me now is only because I've seen it hundreds of times. So in the beginning, it's a lot to take in. And when I was a senior registrar, I would always give this advice to the juniors who were entering the department of the first time. I said, your time in a nat path will fluctuate. For the first 6 months, you'll feel this exponential increase in new territory, learning new terminology, new skills, how to cut a colon, for example, how to interpret what you are seeing under the microscope, how to report it, how to describe it, how to order stains, how to think like a pathologist. It reaches a point where you want to quit at around the 6 month mark. But I told them that 6 month mark passes, and then you get into a rhythm, you establish your flow, you get used to the system, and then you actually start appreciating the sheer beauty and amazing discipline you're in. Like, for example, to see a tumor like under the microscope for the first time, it's fascinating, and I may be biased because I do like an path, but I think bearing in mind all the stuff that you are doing, it's always important to think, wow, this is what I'm looking at under the microscope. This is someone's mother. This is someone's grandmother. I am diagnosing this breast cancer. I am doing these stains because I want to get this report out. I want this report to be looked at by an oncologist who will initiate management and make a meaningful impact in this woman's life. So I think that's what kept me in check as a reg. Is like always when I would get a report or a request form, I would look at the name, patient's name, and think, okay, this is someone's mom. This is someone who is going through a very traumatic, psychologically intense experience. Whether this lump in their breast now, is it a tumor? Is it a abscess? And we make that call. So the workload is intense, but to take in mind and be mindful of the impact you're making really makes the journey a lot better. And, you know, what's stressful are the two sets of exams. But I was very fortunate enough to have a solid set of senior registrars who helped me along the way. And although our department was small, my consultants really prepped us for exams. So the downside is just the sheer volume of work and the stress in preparing for your exams and meeting all your requirements. But you learn how to get around it. You find your support structure. The only advice I would give, those going into a reg program is to not neglect your family life, your life at home, because we can become so consumed with, writing that exam and getting through that we forget that, we also, the life exists once you leave the laboratory at 6 p.m. Like, so it's work-life balance is possible, but it's also the onus is on each individual is to realize that for themselves. And I think what's really nice now that from what I've seen in congresses recently is that the departments in each of the teaching institutions are really well staffed. Like for the first time in a long time, there are enough, or not enough, let me put it this way, there are growing numbers of consultants, more registrars. There is this surge of interest in NatPath despite our severe shortages. So yeah, there's like, and there'll always be good days, there'll always be bad days. Some days you'll be, shouted at a consultant because you did something wrong or, you didn't sign out a case properly. But for every bad day, there's also a good day. And I think it's important to always keep the end goal in sight. And that's like I said, I wrote my goals. I had them visualized at all times in my office. And yeah, like everyone's challenges are unique and life continues even though you're a registrar. You will experience a multitude of different things. Your life, your personal life, you cannot really, ignore. But at the same time, it's also important to not um, neglect it or neglect one aspect of your life for the other. Yes, focus on work, but don't neglect your personal life and your priorities as well. Bearing in mind a lot of things, you have to sacrifice. You can't you really go out, or if you're a social person, you need to like narrow down and but at the end of the day, getting through an exam, getting, capped at your graduation at the CMSA, those are such huge milestones and it makes it all worth it in the end. And it's a short-term sacrifice for a long-term career. That's how I always thought of it. And at the end of the day, you'll always look back and be like, I'm glad I did this because I'm here now. And yeah, like those 4 years can go really quickly. I also can't believe, like, in the beginning, it seems like, oh, will I ever finish? Will I ever become a consultant? But then they fly past because you become so busy and then, yeah, so everyone's experience will be unique, is what I'm trying to say. But good days happen, the bad days happen, the workload is a lot. But with experience, with time, with every case you see now is something you load in your database for a future case. Like things I've learned in my first year, I remember now because it shaped who I am today. And then the more you see, the more you know, the more you grow. So by the time you're a final year reg, you've seen so much, and then it becomes almost like clockwork. So it's a lot of sacrifice in the beginning, but it's really so worth it. I can really say that.
Hmm. I think one thing that we don't talk about enough is being an adult student. Like for us as medical doctors, you finish your internship at the age of like 24, 26, somewhere there. Then 27, you're doing your community service, and then maybe you do some AMO time if you're not lucky to get straight into reg time. Then now at the age of like in your early 30s, you are an employee, you are a student, you're a master student, but you're also in training in terms of your clinical work. So one
Yes.
thing that I think we don't talk about it enough is trying to figure out like practically speaking, when do people study? Like, what tips can they give people? Because it's so difficult to like find your rhythm. Because I mean, different things work differently for different people. But I think looking at it from people that have done this, that have sort of found, a method that worked best for them, it's important for me to ask even you now to say, when
Yeah.
do you study? Because there's an M-mate that you need to do data collection and you need to make sure that it's run, you correct whatever the supervisor says you must do, but also you're running a lab accountable to patients and physicians and surgeons that call you that need the results, but also you need to study for your exams. When do you guys study? Like honestly, practically speaking, what would be your tips, in terms of when should you study, when should you do your M-Med, just so that people get, the rhythm earlier on rather than trial and error.
Mm. I think if I can just give one piece of advice with regard to studying, is that you need to not isolate studying as something you do before the exam. You need to assimilate it into your daily life such that it becomes a normal part of your day. For example, when I was preparing for part one, I didn't start learning 6 months before the exam. From the very first few weeks in the department, I started making notes. I would summarize Robbins. I would make sure and the thing is, you don't look at the time as studying. You're just doing this daily. You do a little bit every day. It doesn't feel as laborious as studying for a 6 week block before the big exam. Silly things like, the main textbook they examine is Robbins' Basic Pathology or Robbins' Pathological Basis of Disease. I would read that book just a little bit, even if it was 5 minutes a day in between while I was having supper, while I was waiting for something, I had it on my phone. I would just read something. You try and do a little bit every day so that it doesn't snowball and become a lot that you have to cover at the end closer to your exam. And that way, the little you do every day becomes so ingrained in your head. And you need to look at every single opportunity to learn. So, say, for example, in my cut up today, I got an appendix, a breast, an ovary, and a gallbladder. Those are the typical specimens you get in your first year, first few weeks when you're still learning to cut. So treat every specimen, every case as an opportunity to learn. Say for this ovary, for example, I get, a case of endometriosis. What I do is I go to Robbins that night. I read about endometriosis. Not only does it help me with my report for the patient the next day, but at the same time, endometriosis is an important slide in a part one exam. It's also a big theory component in the theory paper. So now I go and I read that endometriosis chapter, the section in the chapter. I learn it, and then I tick it off the list. So you see, I didn't go and set time to go and learn about endometriosis. I had a case today. I used that case as the opportunity or the vehicle to learn about the disease. So you can see these small things like, as you accumulate more knowledge as you progress through your time and your training, you use every case as an opportunity to learn. And then even when it comes to the more hardcore learning, like, you have to learn certain genes and so on, do silly things to help you remember. And remember to always reward yourself. When it came to the 6 months before my exam, I'm a huge Marvel fan, for example. I would reward myself at the end of the week. If I had worked enough and I had met my goal, I would watch a Marvel movie on Disney Plus. So it's also important to, not make yourself limited and forget others because otherwise you'll burn out very quickly. You reward yourself for the little things, like just getting through a chapter a week. That is good. That is, commendable. So I think it's this whole paradigm shift where you mustn't think of studying as something you do just before the exam. If you assimilate it into every aspect of your life, and even in the smallest of ways, it ultimately becomes less of a chore. And by the time, that's why even when I got to part two, I had made all my notes a long time. And the thing is, I didn't rush and read it towards the end. I had been going through these things like since the beginning. And that's why when I got to part two, I was calm. So I would think, is in summary, assimilate studying and learning what you need to know into every aspect of your life. And then just be consistent early on, which is tricky, but then, it's easy to do a little bit every day rather than a whole lot at one go later on. So, and in every registrar that I had the privilege of mentoring that came after me, I would always tell them, you know what, don't do what everyone does and read the textbook towards the end. Every day you go through it. So they said by the time you reach your exam, you would have read the textbook from cover to cover 5 to 6 times. But it is realistic and it is doable. And you can do it if you just break it up into simple chunks to make your life easier.
Thank you so much for that advice. I think that's more practical, more realistic, and I hope that I wish, like even from mid school level, people just get into that habit. It's just that in mid school, you have a set learning objectives that you need to
Yes, yes,
measure
yes.
yourself against. But the nice thing about learning when you're specializing is that you know exactly what you need to know. But I think incorporate your trick in incorporating the studying with the work that you do makes a lot of sense. The other question that I think you haven't answered is calls. So like when you're on call as a consultant versus when you're a reg, what does call look like?
When I joined the department, what they said, the benefit of a NatPath is that when you are on call, even when you are on call, and I put call in inverted commas, you go home to your own bed at night. So your typical working hours in the NHLS are from 7:30 to 6, and that includes your overtime. So that if you look at the hours, 7:30 to 6 p.m. every day, it sounds like a lot, but that's a 56 work hour week. So that translates to someone working like an 8 to 4 and doing one overnight call. So the whole purpose of that is to ensure that our overtime aligns with the overtime of our clinical counterparts in the Department of Health. So as a registrar, you don't really make many decisions without your consultant, and that's the one big difference between the clinical disciplines. For example, as an obs and gynae reg, you can go do a Caesar, probably on your own, most likely on your own, actually. However, you cannot authorize a case as a registrar in an AdPath without your consultant having looked at it. So there's less autonomy because of the sensitive nature and because it's such a vastly different field to you're not really exposed to in your undergraduate years. But the calls, like say, like it varies per institution, but the consultant on call for the week, they will handle all requests for autopsies, handling the roster, allocating cases, ensuring things are done, going to the lab if there are any issues, handling, clinicians' queries. They handle that kind of thing, right? The laboratory consultant on call. Called in private work a little different. So when I'm on call or cover twice a week, and what that means is that if there's a late frozen section, I will have to do it. And I will do all the cytology and I will handle all calls and queries. And say Wednesday is my main cover day or call day. So if there's a frozen section that's booked for 5 or 6 p.m., I will do that late frozen section. I will do all the cytology for the day. And if there's any query that comes to the lab, I have to handle it. So that's what I cover on a call day. And the thing is, the calls can come at odd hours. The one time it was Christmas week last year, I got a call from a surgeon who was asking me something very specific. He wanted to know what was the price of a FNA sample. And he's calling at 9 o'clock. So switchboard will put the call through to me. So you have to deal with a lot of like, sometimes it's not even pathology related queries, but because you are the pathologist on call, you have to answer the clinician's, what query or question that they have. So the call is not really like, because unlike pathology, well, microbiology and chempath, when they are on call, they are like awake. And if there's an abnormal UNE, they have to call the doctor. So like there's a lot more real time, emergencies. However, in that path, the calls are not that bad at all, and you are at home in your own bed. When so the one discipline where being on call is not actually that hectic, but yeah.
Yeah, no, sign us up. You must just sign us all all up. That sounds like a dream. It sounds like a dream, absolutely. And I think the last question I'm going to just I'm asking my last question that I'm just gonna ask questions from the floor quickly before we let you go. Is there's different motivations for us to go into different discipline, but the biggest thing that we as doctors put it as a taboo is actually talking about the financial reward of doing different things in terms of is it financially feasible or not. When it comes to pathology, specifically anatomical pathology, in stage, if you are a general surgeon, neurosurgeon, or whether you are obs and gynae, so long as you all have the same qualification, there's a benchmark in terms of your salary. This is how much you're going to take home. So NHLS being part private, part state, that type of a thing. When it comes to your earning potential there, is it fixed or is it better than the specialists in the state sector in the other disciplines? I mean, private, it's straightforward that obviously the earning potential is a lot more, but like if you can give us an idea of how the earning potential is like.
Post qualification, if you get a post at the NHLS, you are called an entry level pathologist. Then after 3 years, you qualify for a senior pathologist post, but you have to apply for that. And then after 5 years, you are eligible to apply for a principal pathologist post. And then that's generally what you'll finish as, right? So it goes entry level, that's immediately post qualification, senior after 3 years, and then principal after 5 years. And then if you become the HOD or so and so on. And these all have specific salary brackets, minimum, medium, and maximum. So it's a range. And why they do that is that there's space to negotiate. Say if you're coming from private back into state and you have room to negotiate, that's why there's a salary bracket. And these are, they circulated. So I would say that, it depends on post availability. Like I had to go to private because there was no post at the time. The post came out like soon after I had accepted my post at Lancet, which is unfortunate. So it's always about a matter of funding from the NHLS, like how many posts can they fund at any given, how many posts can they fund at entry level, how many posts can they fund at senior level, how many posts can they fund at principal level, and each level has specific requirements and demands. Entry level, you are doing more service work to improve your diagnostic skills. At senior level, you do service work plus more teaching because you have that skills. Principal, you do a little less service work and a little more teaching. Well, those are your benchmarks for how you're supposed to split your time. Um, but like I said, yeah, there's a salary range and there's room to negotiate. But important to mention now, and I should mention this, when I signed my contract in 2021, I did not have to do 2 years of work back to the NHLS. But from 2022 onwards, every incoming registrar in the NHLS, it doesn't matter what discipline, Anat Chempath, Med, Micro, or Viro, you have to do 2 years of compulsory work back for the NHLS before you can leave to private. The downfall for this is that, okay, the positive thing with this is that you are guaranteed a job upon qualification. The downfall is that they generally the clause in your contract says they can post you where the service need is greatest. So I haven't heard any major stories because I haven't really heard, no one from after me has qualified yet in terms of service work back. They're about to write their final exams from that cohort. That's 4 years ago. So we'll see now upon qualification where they are actually placed. If it's in the same institution where they were trained, or if it's in, another. Now the problem here is a NatPath, there are very few places you can go. You can only go to the major centers. So most likely for a NatPath, you will, dare I say this, remain at the center you trained at because there's a need for pathologists. But if you are in micro or chempath, I'm not sure how they will post you where the service need is greatest. So right now at the NHLS, you sign a 4-year training contract and then compulsory 2 years work back. But it's good because it means you are guaranteed a post after qualification.
Hmm. And the centers that you can work at, it's UCT, Stellenbosch, uh, KZN, is it Lutuli, Albert Lutuli?
But it's really,
And
and then
then I'm assuming Verse also has, and then where all the big universities has,
yeah, I
Medinta
said
should have, Pretoria should have, and then
yes.
Free
SMU.
State,
Free State and then Mthatha, the Walter
and then
Sisulu, yeah.
Mthatha. Okay. And then in terms of the entry level at NHLS, once you qualify as a consultant, I mean, you won't know because you don't work there.
Yeah,
Is
I
it the
would I would
same
actually
rate
know that. Yeah, yeah.
as us in the state, or you just find out, or you negotiate because it's part
The
private?
thing is, it'll be different for everyone. They do listen to negotiations as far as I know.
Mm.
But I'm not sure how it is aligned with clinical specialist level posts. I
Okay.
know that there's always going to be salary disputes, but I'm not sure how it is aligned at specialist level. But as a registrar, they try and align it very closely to your clinical registrars in the Department of Health. But at specialist level, I know like how you get grade 1, 2, and 3 MO. I'm not sure how it applies at specialist level because I think at specialist level it's just and in a clinical department it's standard. But pathology, they have stratifications as entry, senior, principal. So I'm not sure how that works, but just know that in path there are stratifications at specialist level, and yeah, that affects salary.
Mm. Okay, that's actually very, very interesting to actually know. Actually, NHLS functions a little bit different from us, but I think if we didn't have this conversation, none of us would have known that. How does it actually work? So I think from the floor, I'm not sure if there's anyone who would like to ask a specific question. You can either type or put your speaker up if you have any specific burning questions before we let Dr. Harry go.
Good evening. I have a question. Can you hear me?
Yes, you
Yeah.
can ask. We can hear you.
Yes, Dr. Harry, thank you so much for the talk. It was very informative. My question is, are there any courses that you can do prior to getting into a net path that can help with your knowledge and boost your CV? I've tried to find courses out there, but it's quite difficult. I don't know if you know of any. Thank
Okay.
you.
So there aren't any courses as far as I am aware. It's a different thing if you are applying for forensics because then you can always do the diploma in either forensic pathology or forensic medicine, and that helps in them. But for a NatPath, there is nothing, and they are aware of this, and it doesn't affect, whether or not you get into the program or not. Something to consider though, is writing the Royal College exam. But like I say, that is something when you're in the program because the part one is very much like part one in your ANAT years. It's a Robbins based, it's multiple choice. But specifically prior to your entry into the Reg program, there aren't any courses and they are aware of this. But if you have any specific questions regarding how to prepare for an interview or how to prepare for your time in the lab, I'm more than happy. Queen, please share my details, my WhatsApp, my email. I'm happy to help anyone who's willing to go through the NAT path route. So yeah, of
Thank you, Dr. Harry, for answering my question. Can I ask one more question?
course, of course.
As a specialist in private, do you also do cut up? I know that in registrar time you must do cut up, but once you're a specialist in private, how does that work?
Look, it depends on the lab. Like we cut like difficult specimens, we will always be called to cut. Like, your Whipple's pancreatico-duodenectomy specimens, anything that's a big specimen that's complicated, we will put through. But because of the volume and time, smaller things like, gastric biopsies, our technologists put through because those are done overnight. But they will always call us if they are in doubt for any big specimen, and that's where we are really useful. But things like where you're just essentially putting the tissue in a cassette, they don't call us. And then because of volume, we don't put those through. However, certain labs, I know, well, other parts of the country, I know in Cape Town, some of the private labs, one path will spend the day doing cut up. So I'm not sure if you've visited any of these labs, but if you do want to visit and just see how put through works, how cut up works, they're more than happy to, allow you. And then even if you're visiting the state center, we always welcome people who want to observe and learn. So yeah. But to answer your question, it depends. Smaller specimens usually no. Bigger specimens, yes. Depends on the complexity of the specimen.
All right, thank you so much. I don't have any more questions. Thank you.
All right. Yeah, thank you so much for the questions, guys. And then one final thing, Jason, with regard to mentorship, shadowing opportunities. If there's someone listening to you and they're like, you know what, I just want to spend time in anatomical pathology, what would be advised? Should people just contact their nearest center and seek opportunities to come and shadow and in that way try and find mentors, or what would be your advice to everyone else?
So if anyone wants to do that and is really interested in a career in an ad path, I say go for it firstly. And you approach your closest academic center and they will be more than happy. And I've seen this across the country. We are incredibly happy to invite someone to the department, have them shadow, observe, learn, and hopefully get inspired to apply for the program. I am very passionate about medical education at both the undergraduate and postgraduate levels, and I'm still involved to it in some extent. And if anyone is looking for some form of mentorship, any questions, I am more than happy to help. Even anything I haven't covered in this session, I'm contactable by email, WhatsApp. I love helping people address issues or queries in an AdPath. So I'm gonna ask you to share my details with anyone who wants it. And yeah, I'm very happy to mentor anyone as well. And I
Mm.
have experience both in the private sector and in state sector, so I can give you a more comprehensive like overview of what the demands are wherever you choose to practice one day and so on.
Yeah, no. Jason, thank you so much. I think the people that are going to listen to your recording, honestly, we do appreciate the teaching and the light bulb moment that you've given us. Not just me, but everyone else, in terms of shedding light on anatomical pathology. I think me, should you have told me all these things back in the days, maybe I would have made different life choices, but that's beside the point. So we just want to get more anatomical pathologists, and I think we've achieved that. And yeah, no, all the best of luck. I'm so proud of you.
Thank you.
And every time I think of anatomical pathology, you will be the first person that comes to mind. And thank you so much for offering yourself to mentor others, because I'm a firm believer in that we grow as a community and we
Pay
achieve
it
and
forward.
we
Yes.
multiply as a
Yes,
community.
exactly.
I love that. I love that. Thank you so much for the conversation. I really learned a lot, and I think everyone did. We will definitely share your recording and your contact details, your email. If you can just type your email for us there now, and then yeah, for anyone
Uh,
that wants to get in touch with you, then we can just forward your details.
I just personally want to say thank you so much for this invitation, Queen. It's been so great just to catch up with you in this platform, but also it's really gratifying to be able to share my experience. And if I inspire just one person to consider vaguely a career in an ad path, I will have considered my day made, my one of my life goals complete, just to inspire one person to apply. And thank you so much. It's been an absolute pleasure and a privilege to be able to address everyone. And yeah, I'm very, very excited. Yeah, happy to
Yeah,
help.
I think you've inspired more than one. That one I can tell you upfront.
I'm so
You've
glad.
inspired more than one. Yeah, no, thank you so much for shedding the light on such an important topic because we do need more anatomical pathologists. And thank you everyone for joining. Good night.